So, the next two tests, like I said, are without fixation. So, you need infrared goggles for these. Many clinics nowadays are getting this equipment, so it is likely that at some point you may have access to it. But regardless, it's good to know what to do in these situations. So, do you have any known dizziness or vertigo or anything? So the idea with this is that I'm gonna take her head, I'm gonna turn it back and forth quickly 20 times. Okay? Why do I have to do this?
To get her dizzy.
Say it again.
To assess a post-rotational effect?
Yeah, that's exactly what we're looking for. So this is called horizontal head shaking, and we're looking to see. So what's happening physiologically here? When I turn someone's head to one side, what do we say is happening at the vestibular nerve? It increases, right? If I turn her head back and forth, both sides should increase, right? So what I'm doing is maxing out her vestibular nerve on both sides. Nothing damaging, just increasing the vestibular nerve firing rate on both sides. If there's any problem on one side, what we call a hypofunction, remember we talked about this, then one ear is not going to make it quite as high as the other ear, right? So I'm turning her head back and forth, we have a firing rate increase on both sides. If one of them can't get there, then we have, once again, that relative asymmetry between the two vestibular nerves, right? So if after I shake her head 20 times, she opens her eyes and I see a nystagmus, it's because the brain thinks the head is moving because there's an asymmetry between the two nerves. Make sense? The other thing I like to say with this is that when I'm turning the patient's head, I usually just tell them to close their eyes because it's not that it's unpleasant, but it's just nice, better. It allows them to relax more when their eyes are closed and you're turning their head back and forth. And then about, let's say, turn 18 or 19, 17, 18, 19, you want to tell them to open their eyes. Because if this nystagmus is here, it's going to happen right away after they open their eyes. So if you wait till 20 and you have them open their eyes, you may actually miss the nystagmus. So the idea is, you tilt their head forward again, you have them close their eyes, you shake it 20 times. On 18, you open your eyes, you open their eyes, and watch for nystagmus. Okay?
So this is not necessarily essential stuff, right?
Yeah, this is assessing for, well, if this is positive, usually it gives us an indication that there's a hypofunction on one side. And that hypofunction will follow the nystagmus, right? Still want to go for it?
It's my CI did this to me a few weeks ago.
Oh, really? Were you in a vestibular clinic?
Yeah. Well, it was outpatient, but they had vestibular also.
Great.
So we had the goggles.
Perfect. Okay, so you're used to this.
Yeah.
So I'm going to tilt your head forward. And why do we tilt the head forward? A little horizontal. Yeah. Tilt the head forward. I don't have to instruct her to look anywhere because she's under the infrared goggles. And you start shaking your head 20 times. 1, 2, 3, 4, 5, 6. I'm not going to make her go through the 20. But you shake her through the full amount. Let's say I'm shaking it. 17, 18, open your eyes. See how I keep shaking, and then I stop. And then on the infrared goggles, you'll be able to see if there's a nystagmus. Okay?
Are you in the dark for this? Like, yeah.
The patient is in the dark. The key is it has to be relatively quick, kind of like how I just did it. Common mistakes are waiting till 20 to have the patient open their eyes. Or after I'm done turning, I say open your eyes, and then I allow her to bring her head up. She brings her head up, we're going to have the VOR kicking in and bringing your eyes down and kind of canceling out probably any nystagmus that would be there. Okay? Did I forget anything? There's Dr. Lotan.
No, you're good.
Good?
Why couldn't you do it without the camera?
So this is without fixation, so if you don't have infrared lenses, you can't do this. Because in room light, if someone has a peripheral lesion like a hypofunction, they're going to suppress the nystagmus that comes up. Okay. And since we're assessing for a peripheral lesion, it makes sense we need to put this in the dark. Okay. Any questions with that? The second test is you put the infrared goggles on her. It's called the tracheal pressure test. You put the infrared goggles on. Then I want to press on, literally on her tragus over here. Do you mind if I press? So you have her open her eyes. Infrared goggles are on. I might as well do it on this side, or you guys are on this side. And I just press on the tragus here. I support her head on this side, and I just press in and hold it for a few seconds, and then slowly let go. Okay? So what is that doing when I press the tragus in? So if I hold it in hard enough, it closes off the ear, the outer ear, right? And it changes the pressure in the outer ear. Okay. In a normally functioning ear, the outer ear should have no bearing, little or no bearing on the inner ear in terms of pressure. So I can press this relatively hard, and there should be no effect. She should have no dizziness, no vertigo, no eye movements. There's a condition we're going to talk about in the next lecture where you could have an abnormal communication between the outer ear and the inner ear. And so if I change the pressure in the outer ear, the person's eyes will actually drift, or will get a nystagmus. So abnormal response would be, well, let me show you how it would be. So I'd say, I'm just going to press on the outer part of your ear here. When I press in, or when I let go, I want you to let me know if you feel a sensation of movement, vertigo, dizziness, any of your symptoms. And also, I want you to keep your eyes open so I can watch them. Okay? So then I stabilize her head on this side. If I don't, when I press, her head will turn, right? Stabilize her head on this side, and I just press in like this. I slowly but firmly press in, hold it for a few seconds, and then slowly let go. She can have a nystagmus on either pushing in or letting go. And it can actually reverse. It'll go one way going in, and it'll go the opposite way going in. But either way, any eye drift is abnormal. And we'll talk about what this means in the next lecture. But for now, just know what makes it positive.
You show me on this side of the test.
Yep. So,
You're blocking off the whole ear, right? Like,
yeah, you're actually closing off the ear.
okay.
Like this, right? So what I'm going to do is I'm going to press on your outer ear here. I'm going to press on the ear. What I want you to do is keep your eyes open and let me know if you feel any sensation of movement or any dizziness or any of your symptoms, okay? I'm going to support here and then press on the tragus. Hold it in for a few seconds and then let go.
And then you just look at their eyes.
So her eyes, if you have to use infrared lenses for this, but her eyes will be projected either on a screen or on your computer. So you'll be looking at the computer. If you do this in room light, she's going to suppress it. Right? Good, thank you.
You're welcome.
All right, break off.